Good morning, it's Dr. Rutledge, and I'll be talking to you today about marginal ulcers. And so we'll go right to the screen. All right, mini-gastric bypass, technical errors, tips, pointers, prevention, and management of perforated marginal ulcers. And to be a little bit confrontational to start it off, often the surgeon is the problem. And we'll talk about a variety of tactics and errors, but we'll include things like the twisted pouch and anterior gastro-jejunostomy, the whole concern about ischemia, and well, obviously, that's not a good idea. So let's go forward. I'm happy to announce I'm working with Dr. Ilan in San Diego and in Tijuana, and we have a thriving practice in bariatric surgery, including the mini-gastric bypass. So thank you, Dr. Ilan. And of course, I have to thank my old-time friends, Dr. Kular and Dr. Magenda, who took care of me during the pandemic. We were trapped there during the lockdown, and he was kind enough to put up with me. And so I have to give thanks to him for over a decade of us working together on the MGB. And of course, lots of other friends, Dr. Bondari, Dr. Dietl, Dr. Hargroder, Dr. Musella, and many, many more. So I will try and name everyone, so forgive me. Okay, marginal ulcers. Well, we've known about it for a long time. Here's a 1921 study. And here's one in 2009 about Roux-en-Y gastric bypass, and they saw a 5%, which is, you can see a pretty serious problem. 7% in this study. Marginal ulcer, stomal ulceration, we kind of all know that. One of the most problematic postoperative complications for Roux-en-Y. What about MGB? That's what we're talking about today. Well, I found this study particularly worrisome. This is from the New York database. Overall cumulative incidence at 8 years was almost 1 out of every 10, more than 1 out of every 10. In other words, if you get a Roux-en-Y, you're probably going to get a marginal ulcer. So we'll talk about that. Well, why? Now, everyone talks about acid. And I'm sure we're going to hear lots of discussion about acid before and after. In fact, I know a very good surgeon who does truncal vagotomies because he thinks acid is a big problem. And I hope I can make a case that I think that's a foolish thing to add to a surgical procedure, especially in a perforated marginal ulcer. But remember, the Roux-en-Y is a subtotal gastrectomy. That's removing over 90% of the parietal cell mass. So how much acid can you make if the stomach is gone? That's the parietal cells that make the acid. So my point is that if you don't know what you're doing, it's going to be hard to fight the problem. And so the first rule of Fight Club is know your enemy. And so I hear many people talk about acid, 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 and I'd like to bring up some other points. Specifically, if you think about it this way, if you don't know what you're doing, you might not know how to fix it. So etiology, everyone says acid. Really? Well, not everyone says that. For example, let's look at some other papers outside of the bariatric surgical community. Just a reminder again, the pH in the stomach of patients on PPIs. In other words, most of these patients who present with a perforated marginal ulcer will have had symptoms beforehand, dyspepsia and the like, and usually will be on a PPI, although not always. And even with PPI, you can see marginal ulceration. Well, if the PPI can essentially eliminate acid, then how can we blame acid all the time? I'm not saying that acid doesn't play a role, but this is just a reminder, the acid in the stomach of a pH of 2 goes down to over 6 after a single dose of a PPI. That's a 10,000-fold decrease in acid. So my bias is that everywhere I go when I talk about this, they say acid, acid, acid. I would like to have you think a little bit more about it. Remember, proton pump inhibitors have eliminated the entire surgery of Zollinger-Ellison syndrome. That was a very high acid output perforated ulcer situation, and it's gone because acid is essentially eliminated. Yet, even with PPIs, we often see marginal ulcers. What could be the problem? What if it's not acid? Because if we think about it, maybe then we might better be able to fight it. Again, forgive me for saying the same thing over and over again, but if you don't know what you're doing, you might not know what you're doing. Okay, so here's from some non-bariatric surgery people who are thinking, I think, more correctly. They don't say acid all the time. They say factors include local ischemia. It's not just my idea, although I seem several times when I talk about it, everybody else is focused on acid. Local ischemia, that is how you did the operation. Did you create an ischemic anastomosis? Did you create a location where blood supply was poor and ischemia, anastomotic tension, gastric acidity, yes, non-steroidals, yes, but chronic irritation caused by materials like 2 or 3 fires of the staple gun? All that titanium mixed into dead ischemic tissue is my explanation for marginal ulcers, and another problem that we see, which is a variation in the rate. We see some reports of high rates of marginal ulcer and some low. Well, if it's acid alone, shouldn't that be similar amongst groups? Well, it could be poor quality reporting, but the other possibility is that surgical technique could make a difference. Think of local ischemia, anastomotic tension, and chronic irritation. Here's another paper. The exact etiology of these lesions is unclear. That's not what we hear from most bariatric surgeons these days. They have this focus on acid. We have to get rid of the acid. We have to do a truncal vagotomy because of acid. Well, there's been other theories. Like in the past, Roux-en-Y surgeons used to get wound up about the size of the pouch. Well, an MGB has a very large pouch and doesn't seem to have any more and may have less marginal ulcers. What about foreign bodies, as the other paper referenced? So we're trying to think differently. We're going to talk about how to manage this, but maybe you don't know how to manage it if you don't know what causes it and what's going on. Okay, we'd like to talk to you a little bit about acid and the sleeve gastrectomy compared to the MGB. And this is not exactly pertinent, but we'll just go through it quickly to show you that preoperatively in Dr. Musella's study, there was some acid reflux into the esophagus, but after surgery, the sleeve patients had more acid in the esophagus and the MGB patients had significantly less. There was less acid in Musella's report. On the other hand, we hear from others where there's a lot of acid. So maybe Dr. Musella is dishonest. I don't think so. What if the other surgeons are doing the surgery in a different way? What if it's not even exactly an MGB, but it's an SAGB, which is who knows what? Here's another example from the same paper, and we see that MGB patients get better after the MGB in Dr. Musella's hands. His team, his collaborators in Italy, good results. In the Y Omega trial, bad results. Maybe the MGB is bad, or maybe the surgeons make a difference. Okay, the rate of esophagitis 12 months after sleeve non-acid reflux does not increase in skilled hands. Acid exposure, time percentage decreases after MGB and is higher after the sleeve when the MGB is done using skilled hands. And I've edited those portions of Dr. Musella's paper. In other words, what if marginal ulcers and the difficult and dangerous requirement of repairing a perforated marginal ulcer could partly be related to the quality of the initial surgery, because maybe it's not just acid alone and smoking. And this was brought up recently by Dr. Phoebe and Dr. Bhandari's Paradox. And Dr. Phoebe spoke and said that in the United States, his practice was aggressive diagnosis and treatment of H. pylori, and he reported he had a significant incidence of peptic ulcer disease. When he came to India to work with Dr. Bhandari, he said that they had no assessment of H. pylori, no diagnosis, no treatment of H. pylori, and they had low to no marginal ulcers. Yet we know in India, in some areas, the prevalence of H. pylori is as high as 80%. Why this difference if H. pylori is so critical? What if it is not the difference in reporting, but it's related to the surgical technique of Dr. Bhandari and other surgeons with excellent outcomes? Okay, and also in my series and Dr. Kular's series, that we do not do diagnosis and treatment of H. pylori, and the marginal ulcer rate is well below 1 or 2%. Our hypothesis is it's not just acid or H. pylori. It's related to the surgical technique and those other topics I just brought up, including and most prominently ischemia. Okay, here's a survey of 12 surgeons. Almost all had done more than 500 MGBs and over a decade. And we asked them to talk about marginal ulcers and its management. And this experience is quite different from some in the literature. And it brings up a topic I'm going to discuss more called the MGB Paradox. Good MGB, bad MGB. So how can we have some series of very high outcome complications like the Y omega trial, or others that have very low complications like Dr. Bhandari, Dr. Kular, my reports, Dr. Hargroder, and others? And my suggestion is the answer is not acid only. It's surgical technique and postoperative management. The mini-gastric bypass. This is from a short talk I gave recently, and I would like to talk about the MGB paradox. Some surgeons report excellent results, as I've said. Some say bad results, like the Y omega trial, the Nightmare French study, and a recent study from Australia where 10% of the MGB or SAGB patients were reoperated on within the first few years for reflux. 10%. I mean, I'd stop doing the MGB if I had that. And I would urge that my brother Australian surgeons to stop doing whatever it is they're doing, because that's a bad operation. So what's the paradox? Excellent results in those patients who are having operations done as the MGB's original technique or the Carbajo-Bagua technique, and occasional worldwide reports of poor weight loss, excessive weight loss, bile reflux, marginal ulcer, leaks, and death when surgeons are using other techniques. That's my hypothesis. For example, here's Dr. Lee. Failed restrictive surgery, weight loss was better for MGB versus Roux-en-Y. And I could go on, but MGB expected complication, surgical technique, bioreflux reports, we've seen at 0.3% versus 35%, which is correct. My bias is it's hard to explain. Here's the Y omega trial with just terrible outcomes, 20% gastritis, esophagitis, 20% diarrhea. I mean, don't do that operation. You French surgeons, you part of the Y omega trial, stop doing this, whatever operation it is you're doing. So my explanations of good MGB, bad MGB is the surgical procedure could itself be flawed. Probably not, but it could be. Maybe these surgeons are honest. They've discovered that the MGB is a big trick and it has terrible outcomes. Or it's surgeon technique, and we'd like to talk about some of that today in post-op management. So that's my hypothesis. Here's just a couple of examples. This is a lesser curvature, which instead of being on the left-hand side of your screen here is twisted and kinked. And along with that, you can see a loss of some of the mesentery. And along with that, you could see if that were to be an anterior gastro-jejunostomy with the twist and kink, and poor blood supply from the lesser curvature and absent from the greater curvature, you could have an ischemic gastro-jejunostomy and one likely to ulcerate over time. Here's another more radical example, but it's the same kind of thing. Here's another study from some of surgeons that I asked recently, 12 experts, and we asked them about reflux rates after their experience. So bands, sleeve, Roux-en-Y, and MGB. Look at the reflux rates in these surgical experts. Band high, sleeve high, Roux-en-Y higher than MGB, which around 6%, depending on how it's defined. So their experience as high volume, multi-year MGB surgeons, very low incidence compared to reports from Y Omega and Australia. So everyone's wound up about reflux, but in these experienced hands, these 12 surgeons who just recently did a quick survey for me showed that much lower rates of reflux than sleeve or Roux-en-Y. Here's some other data, estimated rates of marginal ulcers in your patients. We had less than 1% in half of the group and 1 to 5% in the other half. Perforated marginal ulcers, 10 out of the group, or out of the 10 out of the group of 12, or 83% said less than 1%. And there was two surgeons who said they saw it between 1 and 2%. And interestingly, those were the surgeons who reported some of the lowest experience with MGB. Again, at least bringing up the question that maybe that's related to their surgical skills and that they could gain some advantage by talking to the more experienced surgeons. Here's conservative management. How often did you manage a perforated marginal ulcer conservatively? And the more experienced surgeons said never, half the time, and rarely a third of the time. And then the surgeons with a little bit less experience as far as total number of cases and total number of years said sometimes they would manage a perforated marginal ulcer conservatively, and a very small number, 8%, one person, said usually. Graham patch, usually or always, in other words, always. So 1/3 said always, 1/3 said usually. There was a small group who said rarely and sometimes, and nobody said never. And a convert to Roux-en-Y, rarely, sometimes never. There was, again, a relatively inexperienced surgeon who said always. So I won't be recommending that. And T-tube drainage, never in 50%, and I like that. Rarely in a third. Sometimes maybe there's a situation you might do it, I guess, and usually, again, was just one person. So this is kind of what we're going to talk about today. Okay, low versus high rates, the Y omega effect. Why is the ulcer marginal? The acid is everywhere. In other words, like in the MGB, there's acid from the top to the bottom because the blood supply, the ischemia, is at the gastro-jejunostomy. That's why the marginal ulcer is there. That's why the foreign bodies are there. That's why there's a difference, because if you make your anastomosis ischemic by 2 or 3 layers of sutures, by not having a good blood supply, by devascularizing the lesser curvature after you've taken the greater curvature blood supply, you're going to have an ischemic tip. You're creating, the surgeon is creating the marginal ulcer. A lot of people that I heard say, oh, it's acid. Okay, if it's acid, why is there this variation? And why would you ever do a truncal vagotomy? That's not acid, I don't think. Just a reminder again, PPIs change the pH drastically with a single dose by 10,000-fold as far as the pH change. So why marginal ulcer rates are so different? Simple technique affects blood supply. So what we recommend then is, as we talked about, usually it's a brief exploration. Most can be managed with a Graham patch. In cases of severe damage, extensive damage, the best is divide the gastro-jejunostomy and perform a gastro-gastrostomy and get out with drainage. So thank you very much for listening. This is a draft, and I hope you'll be interested in asking a few questions from here. Thank you all very much.